Okay, welcome back, everybody. I'm Dr. Richard Davis Batson, and I'm the Director of Neurotrauma Education for the NEST project. And if you have any questions or feedback, you guys all know how to get in touch with me. We want to welcome back Dr. Gerard Gianoli for the second part of an introduction to post-traumatic dizziness and disequilibrium. Okay, so this is part of the neurotrauma evidence synthesis training, and this program is a traumatic brain injury focused mentored evidence synthesis training program in which we have a number of trainees who are being mentored in evidence synthesis. Dr. Goldenberg is our director of evidence synthesis. He's here today, and we're basically taking young medical students, MPHs, and other students who are interested in learning how to conduct systematic reviews, meta-analyses, scoping reviews, and umbrella reviews, focusing on traumatic brain injury content. So that is the neurotrauma evidence synthesis training. We are supported by the National Center for Complementary and Integrative Health of the National Institutes of Health, and we're funded by the Rand Reach Center. And as you guys all know, this content is solely the responsibility of the authors and does not necessarily represent the official views of the National Institutes of Health. Next slide. Also, disclaimer, this is for educational purposes only and should not be used as a basis for assessment, diagnosis, or treatment of a health problem, medical condition, or disease. And those of you who are seeking personal medical advice should consult with a licensed physician or other qualified healthcare provider. The images and the content in this presentation are exclusively utilized for teaching and educational purposes in accordance with fair use, and no contents of this presentation should be reproduced without written permission of the author, who is Dr. Gerard Gianoli. I want to do another brief introduction to Dr. Gianoli for those of you who were not here last week. And he's got quite the bio, so I'm going to use some notes to get through it. Dr. Gianoli is a specialist in neurootology and skull-base surgery. He completed his medical doctorate in 1986 from Tulane University School of Medicine. He went on to complete his fellowship in neurootology and skull-base surgery at the Michigan Ear Institute in 1995. He was formerly a full-time associate professor at Tulane Medical School until the year 2000, at which time he went into private practice. He is currently a clinical associate professor in the departments of otolaryngology and pediatrics at Tulane University School of Medicine. He has pioneered treatments in superior semicircular canal dehiscence and other vestibular disorders. He's also the editor of the definitive textbook on third mobile window syndrome of the inner ear, superior semicircular canal dehiscence, and associated disorders. He has over 80 peer-reviewed publications and has presented his research at more than 160 scientific meetings while serving on multiple editorial boards. He was the primary investigator for a NASA study that led to non-invasive intracranial pressure assessment to be used in the International Space Station. And he's currently in private practice at the Ear and Balance Institute in Covington, Louisiana. A warm welcome back to you, Dr. Gianoli, for part two. And please take it away.
Thank you, Davis. I appreciate it. I'm happy to be back here and share with you guys my passion, which is inner ear disorders. And this is part two. So just a quick recap of last lecture and the major points I wanted to get across to you guys. The first was that the inner ear was very fragile. And when you've got a brain concussion, you almost always have an inner ear concussion or some sort of damage to the inner ear. And I don't know if you all remember, I showed you this nice video showing a delicate surgical removal of a tumor from the motor cortex. And you can see this retraction of the brain. And it's very delicate, excellent surgical technique. But if you apply that much force to the inner ear, the patient's inner ear would be destroyed, basically. I also came across this I thought was kind of interesting to show to you guys periodically, usually around Valentine's Day. The local news stations will come out with this story about the kiss of death. And if you kiss someone's ear in the wrong way, you can actually cause them to be deaf or lose hearing. And there's a professor, Levi Reiter, who at Hofstra University, who collected a whole bunch of these cases. I think he's got 50 or so of people who have lost their hearing from a kiss. So the big warning from that was don't kiss your baby's ears. But it's just to show you how delicate the inner ear is. Then we talked about how the injury to the inner ears from head trauma is not controversial, and it's very well described in the literature. The first case being reported during the Franco-Prussian War in 1871 by Samuel Moose, and there's been multiple studies since then. We also talked about Harold Shuknick's study over at Harvard, where he taught cats how to do audiograms and then whacked them on the head and demonstrated that their hearing got worse afterwards, and did histology demonstrating the effects on the inner ear without a fracture. And then we talked about how the inner ear damage can be objectively measured and quantified. And in that section, we talked about all the different vestibular reflexes. And these are just, kind of like categories of reflexes. There's a lot of sub-reflexes underneath there, but just briefly, the vestibular colic reflex that causes a contraction in the muscles, and in people it usually manifests as discomfort in the neck muscles where they attach to the occiput. The vestibular spinal reflex, which can cause people to, in lower animals, it causes them to walk around in circles. In people, they tend to drift one side and have to keep correcting themselves, and they can lose their balance. The vestibular ocular reflex, which is the one that most people are familiar with, and it's that reflex to control the muscles of the eye in order to allow us to have stable vision when we move our head. The vestibular autonomic reflex, which can cause all kinds of nasty symptoms, from nausea to increased blood pressure to anxiety and panic attacks. And then we talked a little bit about the cortical projections that and cortical input that can add to that brain fog situation we see with vestibular disorders. Well, next we're going to get into some of the testing and talk about some specific diagnoses. And for that, I wanted to start off by just talking a little bit about broadly about what we can test with the inner ear. Now, remember, the inner ear's got not just hearing, but also balance function. We look at auditory perception. The human ear can perceive hearing, or should I say, sound frequencies from 50 hertz to 20,000 hertz. However, standard audiograms only test from 250 hertz to 8,000 hertz. Now, I have to admit, I don't know why we stopped there. I think it's just because it would probably take a lot longer to test the rest. This is where the traditional hearing test, but you've got way out here between 8,000 and 20,000, some additional hearing that we never test. And there is a means to test it. It's called extended high frequency audiometry. It's a little bit different, and not many places will do this. I would guess it's probably less than 1% of audiologists even have the means to be able to test this. But the importance of this is there can be damage to this portion of the hearing and completely normal hearing in the traditional range of hearing. And I'm interested in this in patients who have head trauma and who have tinnitus afterwards, and they've got normal hearing. And the conventional thought is, well, it can't be from the ear because their hearing's normal. But you haven't tested the entire spectrum of hearing, is my point. And very often what you see in these folks is they'll have hearing loss in the extended high frequency range. As far as vestibular testing, there's a whole bunch of different tests we can do, but the stalwart and the oldest test we have is the caloric test. And that was developed by a guy named Robert Barany from over 100 years ago. He was a Austro-Hungarian physician who was irrigating wax out of someone's ear and realized that when he did that, it made them dizzy and it produced nystagmus. He then used warm water and realized, oh, it caused nystagmus in the opposite direction. And that's what led to the development of the caloric test. And as far as I know, he's the only ear doctor to ever win the Nobel Prize. And it was based off of the caloric test. So that's our oldest test, and really the one that has been the mainstay of treatment. All right, so there's some problems with the caloric test, and let's just kind of go through this. This is the inner ear is a little bit more, excuse me, the balance system is a little bit more complicated than the auditory system with regards to testing. First of all, remember we have 5 different sensors for balance in each inner ear. You've got the 3 semicircular canals, the horizontal, the posterior, and the anterior, also called the superior canal. We give it 2 names to confuse people who aren't in the field. Then there's the utricle and the saccule, which are our gravity sensors, okay? And these, all 5 of these sensors can be stimulated differently, whether they're static or whether you're moving slow, faster, faster, faster. So what I've got listed here is the speed of the stimulus in hertz, which is cycles per second. And so we're talking about moving your head from one side to the other and back in 1 second. That's 1 cycle. Most head movements happen between 0.01 and maybe up to 4 hertz. That's most of your head movements. Of course, when you're still at 0. So the caloric test happens right there at 0.003 hertz. We're talking about so slow that nobody almost ever moves their head that slow. So it's kind of subphysiologic. And one of the things that always was my pet peeve when I was teaching at Tulane is the resident would come back and tell me about the ENG test and say, oh, the caloric tests are normal, so that means there's nothing wrong with his inner ear. Well, obviously, you haven't tested any of these other 4 sensors, and you don't know what's happening in the high frequencies in the horizontal canal. So that's a bad statement. That's kind of like saying if their hearing is intact at 250 hertz, there's no way they can have high frequency hearing loss. So it just doesn't make any sense. Well, there are other tests to be able to test these other frequencies. There's the rotary chair test, and that one will get into those range of head movement speeds that are more physiologic. Downside to that, again, is it's just horizontal canal, and it also tests both of the canals at the same time, whereas the caloric test tests them independently. Then we had active head rotation testing, where the patient can shake their head, and we get from the speeds that the tire end speeds up to speeds that people generally don't move that fast, and generally, especially patients with inner ear problems. And again, you're testing both horizontal canals at the same time. And with the vertical that you're testing both posterior and anterior canals together. So you have to kind of keep that in mind when you look at that test result. Then we've got posturography. Okay, posturography is a static test. And it's really, when we get on condition 5 of posturography, it's a test of our gravity sensor, specifically the saccule, but it's with no movement. You are being completely still. Then there are video head impulse testing. And that's where we have the patient looking at a dot and will move their head real fast in one direction or the other. And we can actually measure each individual semicircular canal separately. The problem is it's at about 100 hertz, which is way faster than what people would normally do. And then next, we've got vestibular myogenic potentials. And this is a test of the gravity sensors, the utricle and the saccule, but it's done with sound at 500 hertz. And then you've also can do it at 4,000 hertz. Now, these are really nice tests because we're looking at sensors that we've not really had good testing for, but we're looking at them at these really, really high speeds. There's also a new test called the ocular counter roll test, where we can measure utricular function, but again, it's a static situation where we're measuring at 0 hertz. And then lastly, there's the subjective visual vertical we can do on rotary chair. Almost nobody does it because it ruins your rotary chair, which is an expensive piece of equipment. And I can do it on my rotary chair, but I choose not to because I want to preserve the life of my rotary chair, which is a $150,000 piece of equipment. So as you can see, this is the red spots are where we can test inner ear function. And as you can see, there's big areas where we just have no ability to even test inner ear function. These are the ones that most of my colleagues are doing, and it's because they get paid for them. And if they get normal results on these, they say, oh, ear's normal, and that's it. Well, there's a bunch of other, besides function tests, there's other provocative tests we can do to look for some specific conditions. Everybody, I think, here is familiar with benign paroxysmal positional vertigo, and there's a variety of different provocative maneuvers you can do to look for positional vertigo. The most common one is the Dix-Hallpike test. Keep in mind the Dix-Hallpike test is specifically looking for posterior canal BPPV. It doesn't really look for horizontal canal or anterior canal. You sometimes can get a clue from the Hallpike test if they've got those other canals involved by the type of nystagmus they have. But if you want to look specifically for horizontal canal, there's a lateral roll test. There's an anterior canal test where you have the patient bringing their head forward, tilted to the side. The bow and lean test is used for horizontal canal BPPV. And in my practice, I use the Omniax, where I put the patient in a chair and I can turn in whatever direction I want to. Then there is endolymphatic hydrops, which, if you remember, is sort of a term used synonymously with Meniere's disease. And endolymphatic hydrops is the histologic finding you find in the ear in patients that have Meniere syndrome. But we can do electrocochleography to identify that. There also used to be a diuretic challenge to confirm endolymphatic hydrops. We would have patients who have low frequency upsloping hearing loss, test their hearing, then give them a diuretic, and 30 minutes later, we'd test again, we'd see those low frequency hearing get better, and that was considered a positive challenge for endolymphatic hydrops. And then for third mobile window disorder, there's a whole host of tests we can do. As I mentioned, my colleagues are really just doing the VEMP testing, usually just the CVEMP, but there's several others that can be done to provoke it and see if they have it. That includes the platform pressure test. In that one, you have the patient standing on posturography on condition 5, where they are dependent on their inner ear for balance, and then you alter the pressure on the eardrum. And if it makes them off balance, that's considered a positive test. There's the VNG fistula test, where we put pressure in the ear and look for eye movements phase locked with the pressure. The Tullio's test, where we introduce sound and look for nystagmus. The nasal and glottic valsalva test, and the VEMP test, as we mentioned. So I'm going to talk a little bit about some specific diagnoses, and these are just some of the more common ones. And probably the most common one of all is labyrinthine concussion. And the diagnosis for this is based on a typical history and findings of inner ear damage. Okay. And the typical history is immediate onset of vertigo and dizziness that slowly gets better. Immediate onset of hearing loss that may slowly get better and may actually go back to normal. Tinnitus, it does not require a loss of consciousness. I know when I've said this before to folks, when I hear the word concussion, they assume, oh, it must be the patient had a brain concussion. No, you don't need a brain concussion to have a labyrinthine concussion. It's just basically a concussive force going through the inner ear causing some damage. As I mentioned, you get gradual resolution of the vertigo. It may get complicated by some secondary BPPV, in which case you'll get these little tiny short episodes of vertigo afterwards. There's variable improvement everywhere from complete resolution of symptoms to gradual improvement over the course of about 3 months. Typically, if it's just labyrinthine concussion and nothing else, you'll see the vertigo and dizziness resolve completely. The hearing loss and tinnitus may not. And as I mentioned, it's diagnosed by the appropriate history and demonstrating on testing that there has been some damage. BPPV, as we mentioned, the Dix-Hallpike test is the one looking for posterior canal BPPV, which is the most common one, and it's because it's the most dependent semicircular canal. The test, it can be done a variety of different ways, and how sensitive the test is done depends a whole lot how it's performed. In this netter drawing here, the physician is just simply looking at the patient's eyes. You'll get a better yield if you use Frenzel lenses, and an even better yield if you use infrared video goggles. It's best to actually look at the video and look for the eye movement as opposed to looking at the tracing of the VNG afterwards, because the bulk of the movement in a posterior canal BPPV is going to be a torsional movement, which does not show up on the tracings unless you specifically have torsional tracking on your VNG, which is not the conventional situation. Keep in mind, it doesn't test for horizontal or anterior canal BPPV. As I mentioned, I use the Epley Omniax, which Dr. Epley devised a number of years ago. I was on his advisory board for his company, and the study to get the FDA approval came through my office, and consequently I have the second device ever produced. Long story short, the company eventually went bankrupt, but I still have a device, and I have an interesting case I'll show you. This is the computer screen you see when someone's on the device. Up top here is a little montage showing you where the semicircular canals are with the patient. Over here is, in the top right, is where the patient is, and of course you've got the infrared video demonstration of their eye. So this is going to be a left Hallpike exam. And it's very interesting in that it shows pretty good characteristics for posterior canal BPPV. It's not like one of these outrageous cases, but it's obviously there. Okay, so here we go. We're laying them back, and imagine the crystals are floating down. It takes 1, 2, 3, 4, 5, 6, 7 seconds before. So you got a 7-second delay before it hits. And as you can see, you've got this upbeat torsional nystagmus. And if you stopped right there, you say, oh, he's got posterior canal BPPV, that's it. But if you keep watching, watch what happens. It slowly turns into a horizontal nystagmus. So this patient also has an element of horizontal canal BPPV. And you may say, okay, well, he's got posterior and horizontal canal BPPV. But if you keep watching, he eventually gets, maybe I think I cut it off, but he eventually gets some downbeat torsional, which suggests he's also got anterior canal involvement as well. And so this patient actually has diffuse lithiasis involving all 3 semicircular canals. But if you just treated the posterior canal, you would probably get him significantly better. He'd still be a little off balance, and you wouldn't quite know why unless you looked for the rest of that stuff. All right, so next we're going to talk about labyrinthine dehiscence, perilymph fistula, third mobile window syndrome. As Dr. Batson mentioned, we just put a book out last year on third mobile window syndrome that goes through all of these, and it's pretty exhaustive. So what are the history that you see with these folks? There's a lot of very variable symptoms you can get with third mobile window syndrome, but there are some very characteristic symptoms, and these are strain-induced vertigo and dizziness, sound-induced vertigo and dizziness, which we call Tullio's phenomenon, after Professor Tullio from like 100 years ago, autophony, where you hear your voice in your ear more loudly and kind of distorted, pulsatile tinnitus, and conductive hyperacusis, which is basically hearing internal sounds louder than you should, like being able to hear your eyes move, joints move, weird, bizarre things like that. You don't have to have these symptoms to have third mobile window disorders, but these are by far and away the most characteristic. As I mentioned, the main test that people are using to evaluate this is vestibular evoked myogenic potentials. And what you'll see on that, especially on the CVEMP test, which is the test that tests the saccule, or the test sending reflexes to your the vestibulospinal reflex, your posture, is that the sounds are, or should I say the vent test is unusually sensitive. And in this particular case, I have a patient where we put 55 decibels of sound and can still measure a vent response, which is wholly abnormal. Typically, a normal vent response, it has to be extremely loud, like at least 105 decibels to get a response. 55 decibels is basically kind of the sound in a relatively quiet room. Right now, you're listening to me about 65 to 70 decibels. So this patient can almost go nowhere without getting sound stimulation to his balance system. And so some of these folks, they will have constant sound stimulation and not even realize it because they're almost never outside of sound of about 55 decibels or so. So this is the nasal Valsalva test, and it shows you this is a patient who I'm going to have him take a deep breath, hold his nose, and blow, and hold that pressure for 25 seconds. And beforehand, we have documented he has no spontaneous nystagmus. And so here he goes, eyes open, and he's holding his breath, and his eyes are a little jittery. But as he gets to the end, you'll see he'll break into a pretty good episode of nystagmus. Here you go. It's kind of a downbeat torsional. And this is a patient with a superior canal dehiscence. And of course, you ask the patient, are you dizzy? And they'll say, oh yeah, I felt like I was spinning, is the typical response you see. But again, unless you do the test, you're not going to see that result. This is an example of the Tullio's test. And this is over here. You might want to turn your sound up to hear the sound associated with this. The one on the left is a little subtle, but it's kind of nice to see. Here we go. See, it pushes the eye up into the left. Up into the left. And you can see with the pulse tone, it kind of jumps around a little bit. Now, that will not show up on a VNG recording. You'll get a little, it'll look like there's just some noise. So you really have to look at the video to be able to diagnose that. Now, the second one over here is a little more dramatic, and this one you probably would show up on a VNG. And this patient is actually humming to himself, and you can see what happens with his eyes here.
Okay, all right, keep your eyes wide open. And do you want me to make the sound, or you want to make the sound?
No, I have to do it.
Okay.
So I have to kind of practice it to get the right pitch.
Okay.
See his eyes kind of move up. Watch when he does a sustained hum.
Okay. Try again. Try to hold that pitch.
Sure.
You know, that last part would probably show up on a VNG, maybe not so much the first several. All right, so the other part of diagnosing a third mobile window syndrome, besides having appropriate history, diagnostic testing demonstrated, a CT scan demonstrating an abnormality. And here we have a patient who has bilateral superior canal dehiscence, and we're looking at absence of bone over the top of the superior canal. Just to make things more confusing, there's a thing called the near dehiscence, where there is bone, but it's exceedingly thin. And we actually have kind of figured out what's the cutoff for how thin does it have to be for it to be significant, and it's 0.4 millimeters or less. And just to give you an idea, 0.4 millimeters is probably about the thickness of two sheets of printer paper. So we're talking about pretty thin. And bone, for you, those of you who've never been in the skull base, when bone gets that thin, it is like paper. It is flexible, and you can move it around with your little probe and all. So it's when you get it that thin, it can transmit pressure and can cause problems. Well, one of the things we figured out early on was there were patients who would show up with third mobile window syndrome have testing suggestive of it, but they didn't have superior canal dehiscence. And we've gradually found there's a whole bunch of other spots in the inner ear when you can have dehiscences. And this is out of our textbook, courtesy of a colleague of mine, Eugene Ionescu, who is sort of the third mobile window syndrome in Europe, guru for third mobile window syndrome in Europe. And he kind of detailed and put together a classification system for third mobile window syndrome, or disorders, I should say. Next, bilaterality. I find my colleagues confused that, oh my God, how can this patient possibly have problems on both sides of their ear after getting hit in the head? Well, when you get hit in the head, that force gets transmitted to both inner ears. And I would tell you bilaterality is more common than unilaterality in head trauma with inner ear disorders. It's just a matter of sometimes one side's affected more than the other. But especially, it's definitely well recognized. BPPV is very common to be bilateral after head injuries, certainly labyrinthine concussion. And as I said, bilaterally is the rule, not the exception with head trauma. Central and peripheral vestibular disorders are frequently seen together. I've been doing this long enough that I've seen patients with head trauma that have central dysfunction, or should I say abnormalities on central testing, that we have no other way to explain it other than the potential head trauma. It doesn't mean it is the case, but it sure is suspicious, and it is something we know that happens to a much greater degree acutely in these folks. Another condition you have to worry about is malingering, and we do see this in patients who have had head trauma, who have litigation involved. And there's a DSM-5 category, or should I say diagnosis, and there's different criteria you need to make that diagnosis, and you can make it. But the way we see them mostly in vestibular disorders are with these four things. Audiometry is one. You cannot fake a hearing test. And unfortunately, there's some folks who think they can fake a hearing test. It's just not possible. I can't fake a hearing test, and I know a hell of a lot about hearing tests. I had a patient in not long ago. He was involved in some explosion and claimed he had hearing loss. And I'm having this conversation with him and said, okay, well, let's go check your hearing. And as soon as he gets in the audiology booth, he does not respond to anything. I mean, this was kind of like, how dumb do you think we are, fella? You just had a conversation with us, and now you're not going to respond to anything. And he had a very obvious case of malingering. We also see it in posturography, and below here I've got a case where somebody was underperforming on their posturography, and I coached him up and told him, I said, you're not trying your hardest, and you don't want this to be how it shows up when I have to go and testify at trial for you. And the second one is his scores after he had his coaching up. And this is basically a normal result, or just barely subnormal, which is probably more appropriate for that individual. So non-physiologic responses are key. And then poor cooperation, of course, is another key. And so we did a study a number of years back, and we kind of looked at how many patients had physiologic symptoms versus non-physiologic symptoms versus malingering. And we could kind of break the litigation group into three categories. You had about 1/4 or 25% where their symptoms fit exactly with the testing we found, or the quote unquote honest group or physiologic group. Then we had 25% where they gave us nothing but non-physiologic responses, and we could not find anything wrong with them, the quote unquote malingering group. The last group, which was 50%, is the biggest group. And in those cases, we found evidence of inner ear dysfunction, but there appeared to be exaggeration of their problem, as in, an enhancement or some enhancement of the testing. And if you look at that, you could say, well, 3/4 of these patients are malingering or exaggerating on their testing, or you could say 3/4 have a vestibular problem, and you'd be right in both cases. So next, the inner ear disorders are treatable. All of these disorders we're talking about have ways to treat them. And I'm going to go through for you guys my approach to these folks. And for somebody who is 3 weeks from a concussion or a head injury who's got some dizziness, really in my mind, I don't think you need to do anything. A hands-off approach is usually the best way to go, assuming they don't have a problem like a severe hearing loss. And the best thing to do for these folks is rest. Don't do anything strenuous in case you develop one of these fistula or dehiscence problems. If you do anything strenuous, it's going to make it much worse and aggravate it. Offer supportive care, treat their nausea, IV fluids, what have you. And so really, and the reason for this is most will get better without doing anything more than that. This includes patients with labyrinthine concussion. You're going to see them significantly better in 3 weeks. They won't necessarily be completely fine, but they'll be better. BPPV, same thing. Most cases of BPPV will resolve on their own. If they don't, then we move on. Whoops, I think I skipped one. Okay. The subacute category, when they're beyond 3 weeks, but up to 3 months. If they're still having vertigo and dizziness at that point, really you're talking about the labyrinthine concussion, the BPPV group. And for those folks, I think it's appropriate to do treatment for BPPV at that point, because if it hasn't resolved in 3 weeks, it's going to need some help with an Epley maneuver or canalith repositioning. Further, if they have labyrinthine concussion, that's somebody who would greatly benefit from vestibular rehab therapy, and they should progress quite nicely over the course of about 6 weeks from vestibular rehab therapy. And then lastly, when the patients are beyond 3 months and they're still having significant problems, those are the ones I think need a full workup and treatment directed to their diagnosis. Now, if they're at 3 months and they're still improving, I think you can let them continue with vestibular rehab. But if they're not getting any better, you're just kind of waiting for, I think you're just prolonging their agony. And there's kind of 4 very common, or should I say prominent diagnoses that come to mind for this. One is the third mobile window syndrome or labyrinthine dehiscence. 2 is endolymphatic hydrops. 3 is malingering, as we mentioned. And the last one we haven't talked about yet, which I call I haven't called it, people used to call it the crippled labyrinth. It may not be as politically correct now, but it's basically a really damaged inner ear that's just not functioning correctly, and it's lost almost all its function. And for that, I'm going to give you just a quick little case here of a patient that I saw last year who had presented to me. He's 38 years old, and he had suffered a fall, fell out of I think it was a 2 or 3 story window, hit his head, sustained a TBI with hemorrhages, contusions, particularly with right temporal lobe, and bilateral temporal bone fractures. Now, right off the bat, when I see somebody who's had a temporal lobe injury, that's somebody you have to think about, are they going to have problems with central auditory processing disorder? So something to kind of keep in the back of your minds. I don't think this guy fell into that category, but it's something you need to think about. He also had a left transverse sigmoid sinus thrombosis and CSF otorrhea on the left side. Whenever someone has a sigmoid sinus or lateral sinus thrombosis, you have to wonder about elevated intracranial pressure in those folks, which will also complicate their problems with vertigo and dizziness. Turned out he did not have elevated intracranial pressure. We eventually did an LP to prove that. He had a profound hearing loss on the left. He was basically deaf on that side, and he had a total facial paralysis. Now, he had problems with balance immediately after the injury, but it continued to get worse. And he'd have episodes of rotary vertigo. The triggers were coughing, nose blowing, movement fatigue, getting up quickly, and ocular motor testing. Well, right off the bat, when he says coughing and nose blowing are triggers for his vertigo, you have to think about third mobile window syndrome, because that's the prime symptom you're going to see with that. Next, he talked about having this boat rocking sensation that would have all the time, and that's suggestive of abnormal stimulation of his gravity sensors. Lastly, he had falls. And a lot of these falls, most of the falls, were without loss of consciousness. And these are drop attacks or otolithic crisis of Tumarkin. Whenever someone tells me they have drop attacks, the first thing, the differential is short. It's brain, the ear, or the cardiovascular system. If it's the brain, it's usually a seizure disorder, in which case they lose consciousness. If it's the cardiovascular system, it's usually due to arrhythmias or drop in blood pressure. Again, they'll lose consciousness. But with the ear, it's typically due to intense stimulation of the otoliths, and they don't lose consciousness. So the big distinction here is whether they lose consciousness or not. And the technical term for it is called the otolithic crisis of Tumarkin. And for me, this is very important because I get aggressive with these folks because this is a potential life-threatening problem. You can imagine if they're at the top of a flight of stairs and have one of these attacks, the next thing you know, they're falling down the stairs. So this is probably one of the more serious vestibular problems we deal with. This was his hearing test. His right ear was almost, it's all within normal limits. He's got a little roll off in the high frequencies, but that's pretty darn normal. Left side, no matter how much sound we put in, he could not respond to anything. This is the caloric test. He gets nice normal calorics on the right side. The left side, he gets nothing. The little tiny bit we measured is actually his spontaneous nystagmus. So this was his posturography. He had free falls on 5 and most of 6, which is a typical vestibular abnormality. This was his rotary chair test, which showed low frequency drop in gains for somebody who's 2 years out from an injury. This suggests he's not having central compensation for whatever reason, and it suggests he's got a fluctuating disorder. This was his CAT scan. Now, the CAT scan of the right temporal bone fracture, it did not go through his inner ear. It seemed to basically just not cause any significant problems on that side. On the left side, however, he had a fracture that actually went through a facial cochlear dehiscence or a cochlear facial dehiscence. And if you look at the labyrinthine segment of the facial nerve, there's a piece of bone in the facial canal. This is a coronal view showing the cochlea right here, and this is the facial nerve, and he's got a cochlear facial dehiscence. So he actually had a fracture through that line, and it caused a devastating loss of balance function and hearing function to where we really could barely measure any residual function in that ear. So my impression for this fellow was he had bilateral temporal bone fractures and TBI, left profound sensorineural hearing loss, left facial paralysis, left severe vestibular loss with otolithic crises and episodic vertigo. Also, I know the left fracture extends through the cochlear facial dehiscence. He had BPPV, probably bilateral, central vestibular abnormalities, and yet he had normal auditory and vestibular function on the right side. So what do we do for treatment? Think about that for a minute. Okay, this guy's 2 years out. I'll be honest with you, these are some of my favorite patients to see because they're so severely affected that in my mind, those are the ones to make better. And the ideal way to treat this guy would be, number one, do a total removal of the last little bits of the inner ear on that left side. He's got no significant function on that side. And if you remove the little part that's crippled or causing this little abnormal function, he's going to go through central compensation very quickly. And in fact, that's what we did. And within a week, he was already better. His drop attacks had stopped, and his balance just continued to improve after that. Probably one of my more happy patients I've had. Additionally, you can do a cochlear implant on this patient. He was not interested in that and actually turned it down, but that would restore his hearing on that side. He also, and in fairness to him, he was kind of mismanaged. He went through the work comp system, which delayed things. He should have had a facial nerve repair certainly within a year, if not earlier. And if you had a CAT scan showing that piece of bone there, it should have been done within the first weeks of his injury, and he would have had a reasonably good facial nerve outcome. At this point, 2 years after the fact, the nerve's not going to come back to any great degree, and so what they're going to do is do a free graft to give him some animation to his face, which is going to be suboptimal compared to a direct facial nerve repair. And then lastly, after the labyrinthectomy, he needs vestibular rehab to help him, his brain compensate. And like I said, I think we did his surgery back in, I don't know, January or March, but he's done fabulous. So in summary, as I mentioned, when the brain is concussed, the inner ear is almost always concussed. These injuries are well described in the literature, and their existence is not controversial. The inner ear damage can be objectively measured and quantified. You just have to do the test to identify it. Objective identification requires appropriate testing, and inner ear damage is treatable. Oh, wait, I forgot. I have one more section to this talk. It's why is it misdiagnosed? Well, first of all, there's really not many doctors that really even are specialized in this. As I mentioned, neurotology, there's less than 350 board certified neurotologists, and this is our specialty. Among neurology, there's less than 100 otoneurologists who are interested in inner ear vestibular disorders. So there's not a lot of folks. There's, like less than 450 in the US. It gets worse though. Most doctors, including neurology and general ENT, do not have the training or expertise to appropriately evaluate these patients. Neurotologists have a financial disincentive to evaluate these patients because insurance companies pay so poorly, they'd much rather spend time taking care of chronic ear disease or even just taking wax out of people's ears. Most neurotologists don't have the equipment for the evaluation. And again, it goes back to the financial aspects of the insurance companies don't pay very well for any of these tests we've just talked about. The symptoms can be vague. The symptoms can often be inappropriately attributed to the brain. And then lastly, there's a thing called vestibular agnosia that I think we spoke about last time, where the patients have vestibular disorders and yet they don't realize that their balance is bad and they're falling all over the place. And so that's basically it for my talk. I have someone had asked about a resource for vestibular disorders last time, and I pulled up, this is a textbook on diagnosis and treatment of vestibular disorders put together by some colleagues of mine at Michigan Ear. And I wrote one of the chapters for this. And we put this book out maybe about 8-9 years ago, but it's getting ready for an update. And I just got an email the other day saying, hey, your chapter is due by December 1. So keep in mind, this is going to be coming out soon, but I think it's a good source for just general vestibular disorders, starting off with anatomy, physiology, and going through the more common disorders, and should be coming out next year. And that's what I got for you guys.
Fantastic, Dr. Gianoli. Thank you again. I want to open it up for question and answer now. So if you guys want to do the little hand raise thing or just jump in. I'm going to start with a couple of questions, Dr. Gianoli, and then I think we're going to hopefully have quite a few. Two things I want to clarify. First of all, the underdiagnosis, you mentioned this last week, and this is something that you and I are very familiar with, the underdiagnosis of peripheral vestibular disorders, even within the field of neurotology, and even when they go to the vestibular lab. Why is it, and we're having this happen in Washington, where they come back and they tell us, oh, it's central only, and then we send them to you, and there's clear vestibular problems, including anatomical dehiscences on temporal bone CT. So tell us a little bit more about the problem of underdiagnosis of peripheral vestibulopathies.
Well, I think it stems from a couple of things we just mentioned. One, there's a financial disincentive to even make the diagnosis because they don't get paid much to do it. My situation is a little different, that I dropped out of the third-party payment system in 2005. So I actually charge cash, and I don't deal with the insurance companies. We give the patients a HCFA form so that they can get reimbursed from their insurance company. So we charge a price that we know we're not going to lose money on the testing, and that's why we can continue to do these tests. But you know, it's interesting when you look at, I had a case recently, and this was a patient who was initially seen at a very famous, dare I say, one of the most famous research medical institutions in the Northeast, who was seen after head trauma. He was dizzy. They kind of said, we don't know, must be brain, or well, I'm not sure. And then he actually had a CT scan done. He gets eventually sent down to me, and I look at the CT scan, and it was an inadequate CT scan. So we did an appropriate CT scan. He had an obvious superior canal dehiscence. I did testing to demonstrate that it was physiologically present. Third, he had the history of Tullio's phenomena, strain-induced dizziness, the kind of classic symptoms you see with it. He then gets sent back to that famous institute, and they reluctantly say, "Oh yeah, oh it's there, but oh it's nothing. It's, you know, it's like huge embarrassment that they didn't get it." And it's mainly because they didn't do the appropriate test on the CT scan. And two, they didn't do but one of the tests we talked about on demonstrating that there's some reactivity from straining or sounds or that sort of thing. And again, it goes back to, it's not that they can't do it, it's because the financial disincentive is there. And if you're working for a hospital corporation, you can only do the test that they'll allow you to do.
Got it. Couple things you mentioned there: temporal bone CT scan, internal auditory canal. Not all temporal bone CTs are created equal. Can you differentiate that for us?
Yeah, so there's a couple of things with that. One is it's got to be a bone algorithm. You have to look at the bone. You can't do a soft tissue. And it's got to be very thin slice, because if, for example, a head CT, you're going to get one or two slices of the ear. It's going to be all compressed together, and you're not going to be able to see anything worthwhile on a head CT. So you need very thin slices, and ideally 0.6 millimeters or less. The imaging unit near me, I've got them to where they do the 0.6 millimeter slices, but they overlap them to the point where they format images that come out as 0.125 millimeter slices. And in general, the thinner it is, the more of the inner ear architecture you can see, and the better you can identify some of these more subtle dehiscences. The last is you got to get them at different angles. And one of the kind of the Hollywood shot of a superior canal dehiscence is this thing called the partial view, where they get the view where you can see the whole superior canal. And it's a nice, pretty one, especially if you can show a dehiscence. Problem is, it's not the best way to identify it from a clinical standpoint. Your best way is to turn around the other way and do slices of the tube. And a lot of my colleagues think, oh, if it's not on the partial view, it can't be there. And that's just total nonsense.
Gotcha. Okay. A lot to talk about on CT scans. Maybe that's another mini lecture for those of us interested in radiology. Got a couple more questions, Dr. Gianoli. We want to talk a little bit more broadly about vestibular treatment. I believe last week or 2 weeks ago, you mentioned vestibular therapy, or PT, medical management, including pharmaceutical therapy, and then surgical interventions. Can you talk more broadly about the types of vestibular treatments, and I think you briefly mentioned when to think about the different type of treatments as well, just to review that.
So, you know, just in general, the best way to think of vestibular disorders is two big categories: fixed and fluctuating. Okay. Fixed lesions, think of someone who had labyrinthine concussion. They had damage, the damage has stopped, and it's stable. Okay. That's a condition where the brain will adjust to that pretty well. And the vestibular exercise, they're basically vestibular exercises, kind of eye-head coordination exercise to help the brain, expedite the brain to adjust to that lesion. Okay. And that's a case where vestibular rehab therapy works extremely well. Then you've got the conditions I would put in called fluctuating disorders, where the function of the inner ear keeps changing. Think Meniere's disease, third mobile window syndrome. I'd even put migraine into that category. But the function keeps changing. And in those cases, the brain will not adjust to that until you've stabilized it. And in those cases, that's where the either medical or surgical therapy, the goal is not to restore the function, but to stabilize it to where then you've converted them to a fixed lesion, and then they will respond to vestibular rehab therapy. So getting over to the patients who have chronic vestibular problems, as in I'm talking about the group that's well beyond those 3 to 6 months after a head injury, they typically have 3 problems, okay? They have an uncompensated vestibular loss, meaning they've done damage to the ear and it's not adjusted. 2, they've got BPPV. And 3, they've got a fluctuating vestibular disorder. And there's a progress or a progression of how you should treat these folks. First, everybody's initial response is, oh, let's send them to PT to take care of the uncompensated vestibular loss. Well, the problem is if you don't fix the fluctuating disorder, you can do physical therapy for the next 10 years and they're still going to be dizzy. And I've seen patients like that. So you have to fix the fluctuating disorder first. If you don't fix the fluctuating disorder, you're going to continue to have an uncompensated vestibulopathy and you're going to continue to get intermittent BPPV. So first you fix the fluctuating disorder, then you fix the BPPV, then you do the vestibular rehab. And it works extremely well that way. As far as medical treatment for the fluctuating vestibular disorders, it depends on what the fluctuating disorder is. But the most common one we see after head trauma in these chronic folks is the third mobile window disorder. And it's kind of 4 things we do. One is we look at whatever medical problems that patient has that will cause some increased pressure in their head, whether it's hypothyroidism or obstructive sleep apnea or anything that will cause some surges in pressure in their head. Or for that matter, too, if they've got frank increase in intracranial pressure, that needs to be addressed before anything else, too. Second is restricted activities. So when these folks strain, they will send a pressure wave up to their head, straight through that third mobile window defect and cause more damage to their inner ear. So a period of time where we restrict their activities where they're not doing anything strenuous. And I've got a detailed list of things that they need to avoid doing. Third is diet. I have them avoid salt. Of course, wherever salt goes, it drags in more fluid, more pressure. I have some folks who are extremely sensitive to salt. Caffeine, avoidance of caffeine. And then third, which is a little more individual, avoidance of migraine triggers. And that kind of does the same thing. And then the last thing is medical therapy, and it's geared toward lowering the intracranial pressure. You can use carbonic anhydrase inhibitors or diuretics for that. My favorite drug for this is acetazolamide. It's not the only one you can use, but I like it because it works so well in lowering intracranial pressure. And that's the medical therapy. Now, if you have someone who does not respond to medical therapy, then we're talking about surgery. For surgery, there's a couple of different approaches. Like I said, first, if they haven't gotten their CSF pressure down to a reasonable level, I'll send them to a neurosurgeon for a VP shunt. Fortunately, that's very few patients fall into that category. But assuming their intracranial pressure is a reasonably lower level, look at repair. We can put bone over areas that are missing bone. That's kind of a more direct approach. Some people actually will plug the semicircular canal for the same sort of idea. Then a more lesser approach, we can do reinforcement of the round and oval windows, which is probably the least invasive surgical approach. It's done through the ear, and we just basically reinforce those windows, and that makes a significant improvement in these folks, especially for the vestibular disorders. The last one I would throw out there is something called interlymphatic sac decompression. And that's done through a mastoid approach. We just basically do a mastoidectomy like we do for little kids with mastoiditis. and then we take bone off of the drainage sac, which kind of reduces pressure to the inner ear and acts as sort of a safety valve, if you would, or a pressure release valve for the inner ear. And that's helpful in some cases. And that's the majority of the treatment for these folks.
Thank you, Dr. Gianoli. Some clarification. We had a question about brain MRI and obviously different than CT scan in terms of its resolution around the bone. But just to clarify that the gold standard is going to be temporal bone CT and not brain MRI.
Right. I always get, I was going to say, I always get an MRI scan as well if it hasn't been done. And for a few reasons. One, to make sure that there's not some other disorder like a tumor cyst pressing on the vestibular nerve. I also look for Chiari malformations because you can see Chiaris induced by head trauma. And then another big one I look for is, and this is something that is another problem that's kind of flying under the radar, is elevated intracranial pressure. And you can't see pressure on an MRI scan, but you can see some findings that are suggestive of elevated pressure. Dilation of the optic nerve sheets, empty sella, Chiari's one, compression of the lateral ventricles, compression of the lateral venous sinuses are some of the things you can do. In my office, we actually have a device that measures intracranial pressure non-invasively. That gives me another clue as to whether these people fall in that category. But as we've seen the obesity epidemic come across the states, so we've also seen an increase in problems with elevated intracranial pressure, and there's papers documenting that as well.
Yeah, and I would highlight also for the group and Dr. Gianoli, even if you're ordering locally a temporal bone CT scan, we've had cases, again, not all temporal bone CT scan protocols are created equal. Not all radiologists have the same experience. Not all neurotologists have the same experience. So really the clinical acumen of the ground level clinician is key, because you may get a temporal bone CT locally and they say there's nothing wrong. But the clinical picture suggests otherwise. And we've had cases like that we've sent down to Dr. Gianoli, and running his CT protocol, he's actually found lesions. So the radiology is secondary to the clinical acumen. So don't assume if you just order a local temporal bone CT scan IAC study and it says no problem, normal, unremarkable, that it necessarily is, if the patient continues to be symptomatic, suggestive, again, as Dr. Gianoli's mentioned, fluctuating lesions and so forth. Okay, Dr. Richard Adler asking a little bit more specific question around the intracranial, non-invasive intracranial pressure measurement. You consulted for NASA. It's a pretty interesting story.
Yeah, I have a device it's got several different names. Some people call it the Marchbanks device. I think Robert Marchbanks is the guy who invented it. He calls it the cochlear cerebral fluid analyzer. I call it the tympanic membrane displacement analyzer. But it's basically a way of measuring intracranial pressure through the ear. And it's based on measuring the movement of the eardrum based on the acoustic reflex response. And there's a couple of requirements for that. You need to have a normal acoustic reflex at 1,000 hertz and reasonably normal hearing at 1,000 hertz and a normal middle ear, which in my practice, which is patients with all kinds of ear pathology, that limits the number that it's really accurate on. But in the ones that fulfill that criteria, it actually is probably about 80% accurate or so. There's only 5 I know of in the US. The first group to get it was NASA, because they wanted to use this to measure intracranial pressure on the astronauts in space. We were the second group to get it. Dartmouth University was a third. The fourth one, believe it or not, was obtained by NASA because they forgot they got the first one. But don't worry, it's just $30,000 of your tax dollars, not a big drop in the bucket. And the reason I know this is because a number of years ago, I got a call from one of the guys over at NASA saying, "Hey, Gianoli, we hear you've got a Marchbanks device." And I'm so, yeah. And can you tell us how many patients have you tested? And at the time, it was well over 1,000 patients. And they're like, wow. And as I understand, you've also done some spinal taps to correlate the intracranial pressure. And I said, yeah. I said, how many of those? And it was probably 400 or 500 at the time. And his response was, wow, can we mine your database? And I'm like, sure, but you guys got it before me. How many have y'all done? Oh, about 20. And it turns out the astronauts will not do a test if they don't have to, because they're afraid of flunking it and getting kicked out of the program. So I did this little study with NASA, and it showed that it's accurate, it's safe, it doesn't hurt. You know, it's like I said, about 80% accurate. And it then led to the approval of the fifth device, which is a very compact, small device that is actually currently on the International Space Station.
Fantastic. Thank you, Dr. Gianoli. Questions keep coming in. This is great. Let's just see. I'm going to try to put these in order. Okay, given that there are so few physicians who specialize in this, do you have any suggestions for patients with chronic fluctuating lesions, I assume, for treatment of symptoms mitigation, which would be local or affordable, meaning we don't have to send them down to Covington, Louisiana to see you?
Well, I think that's a great question, and I do think there's some things you can do. And this is something I've talked to physical therapists who don't have the ability to prescribe medications. In that, I call this Groucho Marx medicine. Okay, so talking about that last patient we talked about, it when he blows his nose, he gets dizzy. Well, don't do that. You know, I know a lot of you guys probably aren't old enough to remember Groucho Marx, but he was a comedian from like the 1930s, and he had a skit where he was a doctor, and the patient comes and says, "Doc, it hurts when I do this," and he said, "Well, don't do that." So that's my Groucho Marx medicine. So first of all, you know, having them avoid straining heavy physical activity, and especially nose blowing, where you can double intracranial pressure. Some folks, you do that and they don't need anything else, especially if they're, you know, like milder cases. Two, the diet is something that anybody can do. Avoidance of salt, caffeine, and migraine triggers are certainly things you can do. And then for the patients that need something more than that, you can even give them a trial of a diuretic or like I said, acetazolamide. There's a little bit more to that than you can imagine, but you can do that empirically. I don't like to do it until I've done my testing, because I find once you do these things, you're going to affect the test results. And so I like to see the patients virgin without any testing, without any treatment, so I can see what is the pathology. And then after that, I can be a lot more certain as to what we need to do to make these folks better. But if I treated them beforehand, then brought them in, and some of those tests that were glaringly abnormal before or not. As a matter of fact, that's one of the ways that kind of help figure out what's going on with these folks. I'll treat them and then bring them back if they're still having trouble, and I'll repeat some of the tests. And what we should see is those tests revert to normal, a number of them.
Perfect. Thank you, Dr. Gianoli. And then I've got a question from one of our vestibular therapists.
Before you go on, one other thing I was going to mention.
Sure, go ahead.
Another thing that these folks that you can do that's very simple, especially if they've got Tullio's phenomenon, and even if they don't have Tullio's phenomenon, it's worth a trial of noise canceling headphones. Okay, and I don't mean just headphones or earplugs, because when you put an earplug in your ear, and we're talking about those folks that have Tullio's phenomenon, sound-induced dizziness, you put an earplug in your ear, it's very effective at reducing the effects of high frequency sound over 1,000 hertz. Problem is, most of the vestibular effects come from those less than 1,000 hertz, like 500. And that's why we do our testing at 500 hertz. And that's the beauty of the noise canceling headphones. It actually puts out a sound that will cancel out the low frequencies. And even in some folks that don't know they have Tullio's phenomenon, just a trial of putting the headphones on, some of those will tell you, oh my gosh, my balance is better. And they don't know why. Frankly, I have a number of patients show up in the office, they already figured that out. and they're just looking for a way to get rid of the headphones. So that's another pretty simple thing you can do.
This is regarding autonomic dysfunction. Let me see if I can find the question. How do you best manage or refer a patient you suspect to have the subcategory of autonomic dysfunction? And I want to add something in, Dr. Gianoli. I know last week you talked about primary autonomic dysfunction versus autonomic dysfunction second to impairment of the vestibular autonomic reflex. So that's the context, I think, of the question. Go ahead, Dr.
Yeah, that's a great question. And I would say I don't, from the standpoint of treating their vestibular disorder, I don't treat them any differently. But I think of them from the standpoint if they've got nausea. Well, yeah, I'm going to give them anti-nausea medicine too. If they're having significant autonomic stimulation that's causing them anxiety and panic attacks, well, I'm going to treat that as well. And typically what I do is I'll start them off on an SSRI like Lexapro, and I may give them a handful of a benzodiazepine for the first couple of weeks just to get them through the first couple of weeks, because the SSRIs, it takes 6 weeks for them to really kick in, but they're great at blunting that autonomic stimulation. And if I have someone who's got a severe vestibular disorder causing a lot of anxiety and panic, once I get them on an SSRI, I tell them, do not stop that for at least a year. And the reason for that is even if I snapped my fingers and made their inner ear problem perfect, their brain still has to go through central compensation. And during that year, as they're going through central compensation, they're still going to get in a little tiny abnormal vestibular stimulation that can kick off a panic attack. And so a very common thing I've seen in the past is I'll treat somebody, they're 6 months out and they're like, oh, I'm perfect. I don't need these medicines anymore. And they'll stop their Lexapro. And then they'll get one little, twist of something and boom, they're off into anxiety land again. And, the story I tell them is, look, you're not supposed to stop until a year. And some need it even longer than that, but you need to keep it until you've gone through central compensation.
Dr. Gianoli, not everyone was here last week. I think this, you covered the 4 reflexes, one of which is the vestibular autonomic reflex. And if you could talk a little bit more about that, and I want to give some context. I mean, before I got a little bit more educated in vestibular medicine, we would refer to one of our dysautonomia neurologists here locally. They would go through autonomic testing. They do tilt table testing. They'd come back with a POTS diagnosis, and there's no referral to neuroautology. We send them to you and find out they've got damage to the vestibular autonomic reflex, and this is really a secondary dysautonomia to the vestibular damage. So can you talk about? So I mean, I guess my question for you is primary dysautonomia a diagnosis of exclusion that requires sending them to neuroautology to rule out impairment to the vestibular autonomic reflex, essentially?
Well, let me put the disclaimer out there. I'm not an autonomic disorders expert, but that said, there's plenty of research show patients with, in particular, abnormal otolithic function will have dysautonomic problems like orthostatic hypotension. If you look at patients who've had labyrinthectomies or lost vestibular function bilaterally, they have much higher incidence of orthostatic hypotension. And it's because when you look at what goes into causing vasoconstriction to increase blood pressure when you go from supine to upright, there's 3 major reflexes. You've got the filling in the heart, that's one reflex or sensor. You've got the pressures in the carotid bulb, and then you've also got the otoliths in the ear. 3 reflexes. The one that happens the fastest and the quickest is the otolith reflex. But it's something that until recently, no one's really been able to evaluate. And that's why I think it gets completely ignored so much, because they don't even think about the ear being an issue, but it is part of what we see causing problems with dysautonomia. Now, I personally think it's hard to say somebody's got primary dysautonomia when you've got something happening that could certainly be the cause of it. So if you've got an abnormal, especially a fluctuating vestibular disorder, it's kind of hard to pin that on primary dysautonomia.
Fantastic. And Shawnee, does that, I don't know if Shawnee, you want to put your microphone on. I find this a fascinating topic just with some of the patients we've sent down to you that you've treated, and literally their panic attacks go away. And so you sort of referred in your prior lectures about these pseudo panic attacks, increase in, classical panic attack diagnostic criteria, but then we treat them with acetazolamide or other medical management. The panic attacks go away. Can you say a little bit more about that? And just I know we've got
Sure.
a psychiatrist here today as well. So
I had a very interesting patient a long time ago. She was 16 years old when she was diagnosed with panic disorder, and she was never well controlled with medication, and was so severely affected she couldn't finish school. She never had a job, never had a significant other, and she was referred to me actually by her psychiatrist when she was early 30s. So this has been going on for like half her life. And the reason the psychiatrist referred, because he had a suspicion that she had an inner ear problem. And sure enough, we worked her up. She had a perilymphatic fistula. I did her surgery, and then suddenly, poof, suddenly she went from having a panic disorder that could not be controlled to, yeah, she would have the occasional anxiety and such, but her life completely turned around. And it was controlled at that point. She wound up finishing school, got a job, got married, had a baby, and she was like, for her, she thought I walked on water after that. But it was basically, I think, her entire life, she had inner ear disorder that flew under the radar. And again, it kind of goes to the most obvious thing people see is the panic attack, but they don't see that, oh, she had an episode of spinning right before that.
okay, great. Another question for you. I was reading that some research shows SSRIs can exacerbate symptoms in post-concussion, and SNRIs were perhaps better tolerated due to less side effects. Do you find that not to be an issue in your experience?
I have not come across that. One of the things I will tell you that I tell every one of my patients is the first 2 weeks you take Lexapro. And it's really, I'm a one trick pony when it comes to treating with SSRIs. Only one I use is Lexapro. If it doesn't work on them, I refer them to psychiatrists who I tell them, look, these guys, they know the best medicines to use, not me. But I have experience with Lexapro, and so that's the only one I really use. But what I tell them is first 2 weeks, it can make your anxiety worse. And that's not just with the post-concussive patients. I think that's with all of them. And the way I kind of ease them into it is I have them take a half a dose for the first week and a full dose the second week. And that's why I give them those handful of benzodiazepines, really just to get them through the first couple of weeks. You get them past the first couple of weeks, they generally do extremely well. Now, it doesn't really kick in until about 6 weeks, but you just got to get them through the first 2 weeks. So I guess in a way, yeah, I guess I do see an increase in anxiety in those first couple of weeks. And I just use the benzodiazepines to get them through it.
Great. Let's see if there's any more questions. If not, I'm going to add one in. We've got a lot of different disciplines here today. We've got neurology, sleep medicine, psychiatry, vestibular therapy, PT. We've got a sleep doctor here. What role of treating obstructive sleep apnea in lowering ICP have you seen? And usually in what degree of sleep apnea does that actually mitigate the vestibular symptoms?
Sure. So I think the biggest kind of connection between sleep apnea and inner ear disorders is the increase in intracranial pressure when they're asleep at night. And it's something that I was not aware of until we started doing a lot of lumbar punctures. And I don't do the lumbar punctures. I have an anesthesiologist do it, and we always do it before surgery. And we would get 2 readings. We'd get one reading. Well, first of all, let me tell you the setting. The patient's in like a recovery room setting. Have an anesthesiologist doing the lumbar puncture. We have a nurse anesthetist who's keeping the vitals. The patient's hooked up to a monitor. We got continuous reading of O2 sat, et cetera. Okay, so no chance the patient's, apneic or anything like that. We get a reading with the patient sedated because they will give them, like Versed or something to relax them. And then we get an opening pressure with them sedated. And then we wake them up and say, okay, wake up. Oh, how you doing? Take a couple deep breaths. And then we get an awake reading. And most people, if I ask them, which pressure do you think is going to be higher? They'll say, oh, the awake reading because they're straining with their muscles. No, the sedated reading is almost always higher. And in some patients, it is dramatically higher. I've had some where their sleeping opening pressure was in the 30s and their awake pressure was in the teens. So I find that a very helpful guide to figure out, okay, what are their pressure at night? And so I routinely check patients who have inner ear disorders. I ask them about their sleep. And if they has any question about it, I send them for a sleep study. Now, I find if you treat their sleep apnea, it generally helps their inner ear problem. I do have a handful where that's still not enough. And I think what's happening in those folks is even though the CPAP is keeping their airway open, their respiratory rate is slower and they're retaining CO2. So they're getting an increased pressure. I had one guy that's in particular very memorable. He had gone deaf on one side, was losing his hearing on the other side, and he had sleep apnea. He was being treated with CPAP. I would go in, and he was one of these ones where we'd get the sedated pressure. He'd be up in the 30s. Awake pressure, he'd be in the teens. So he was quote unquote normal when he's awake. And eventually, and every time we would do a lumbar puncture, we'd drain off CSF and his hearing would come back up. And after doing this 4 or 5 times and treating with acetazolamide, et cetera, I eventually said, no, you need a shunt. So I sent him, first of all, it took me about 5 neurosurgeons before I could get one to agree to do a shunt on this guy because he had normal pressures, right? And so there's this one fella that I've got a good relationship with him and he trusts me, and he did a shunt and poof, the guy's hearing's been fabulous ever since. And I think it's just in his case, even though he was being treated with CPAP, his respiratory rate was still too slow that he would retain CO2 and the pressure would go up.
Fantastic. Thank you, Dr. Gianoli. We've been about an hour and a half, so we're going to be wrapping it up. I'd like a few people to turn on their mics. Dr. Gianoli, I can't thank you enough for 2 weeks ago and today. We're going to want to invite you back. I think you're incredibly popular, just fantastic learning for all of us. Could we get some feedback from the group on if Dr. Gianoli was to grace us with another lecture, what you guys would like to hear about to refine what we've learned about so far? Can I get some feedback from the group?
I'll chime in.
Yeah, Dr. Majeka, welcome.
Yeah. From time to time, we have patients who are not able to sustain sleep because of tinnitus. And so it would be a really interesting topic.
All right, you can kind of split up tinnitus into 2 categories, central and peripheral. Okay, peripheral meaning something is actively going on in the inner ear provoking the sound. Think like in third mobile window syndrome, you're getting these pulse waves from the CSF that's causing a pulsatile sound. Central tinnitus is very analogous to phantom limb syndrome. And it's, if you think of someone who's had their leg amputated and they say they can still feel their toes, obviously their toes aren't there. It's the part of the brain that senses the toe that's kind of activating up. Well, the same thing happens for hearing. If someone's got hearing loss at 10,000 hertz or 20,000 hertz or whatever, there's a part of the brain that senses that frequency. And if it's not getting stimulated, it activates up. And that's central tinnitus. And that's probably the most common sort of tinnitus. And the best, it's a difficult problem, but just the short version of a lecture on that would be number one, introducing sound makes it better. And most patients that have this recognize that they'll even tell me when the first time I meet them, when they sleep at night, they turn on a fan to have the fan sound so they can sleep because they'll hear the fan rather than their tinnitus. There's a whole bunch of other sound producing devices out there that can do similar thing, the sound of the whales or the rainforest or what have you. So masking, okay, for someone who's got tinnitus, that's so bad throughout the day and the normal sounds of the day are a problem, they've got a hearing loss, a hearing aid is a very effective way of treating those folks because it amplifies the sounds that you want to hear rather than this thing in your head. All right, so masking or hearing aids. Second is cognitive behavioral therapy. And it's really more just to have, it doesn't make the tinnitus goes away, but it makes the patient, adjust to their problem better. Those are the only two things that are kind of mainstream treatment for tinnitus. Now, I think there's other treatments that, specifically peripheral stuff, directing treatment to fix that peripheral problem makes the tinnitus better. And those are usually pretty apparent when you evaluate these folks. But again, with the central tinnitus, a number of years back, a colleague of mine went in, put electrodes on the temporal lobe and stimulated, and gosh darn, tinnitus went away. Problem was, and he hooked them up to a stimulus generator to do this. And problem was, over 6 months, eventually the brain got adjusted to it, and you'd have to change how it was stimulated. Well, it turns out you can get the same thing done with transcranial magnetic stimulation. And that apparently works too. I think the biggest problems with the studies using transcranial magnetic stimulation is that there's a number of folks in there that shouldn't be in there. They're like, peripheral problems that shouldn't be in there. But they've got reasonably good results with TMS. And again, it lasts 6 months or so. So that's something to consider in the future at some point.
Fantastic. I think that wraps up questions. We got one more question.
Hi, so I would like to hear more about just the tips and tricks that you've sprinkled throughout this lecture, like wearing the noise canceling headphones. And I think that also I would be interested in some sort of flow chart evaluation. People at a certain point, I'm going to maybe refer them to someone else, but I want to be able to give them a roadmap for if you go to the next level and it doesn't get resolved, well, here's the next level, here's the next level. And, maybe eventually all roads lead to New Orleans. I don't know. But
Yeah, you're going to be doing some primary care. I think it's important for those that are sort of in the primary care setting or they're doing general brain injury medicine to learn more, to figure out how to triage and make clinical decision makings about referrals and realizing when maybe things are not happening with their local providers at a level where they're getting the care that they need. So that's great, Laura. We can try to design that at some point if Dr. Gianoli is willing. Anyone else? I think that's probably it today. Good. Well, thank you everybody for joining in. If you have other questions, feel free to email me and I'll pass them on to Dr. Gianoli. Thank you again, Dr. Gianoli, for your time today.
My pleasure.
All right. Thanks again. We'll see everybody soon, and you guys will get messages on the next upcoming lectures in your emails. Thanks again, everybody.
Bye, guys.